Hello, my name's Roger Henderson. I'm a GP and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. And you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts. So do please follow us to receive notifications about new episodes. And if you're liking what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can also visit GPnotebook.com. Now, in this episode, I'm going to be discussing aortic stenosis, which is a large topic, and I'd like to try and précis it as best I can because it's a common yet potentially fatal valvular heart disease that seems to exemplify the downstream consequences of a seemingly localized mechanical problem on systemic physiology. So I want to look at the aetiology, the pathophysiology and clinical presentation, diagnostic evaluation, treatment options, and the prognosis associated with aortic stenosis, because this is such a common condition that we see in our elderly patients. So let's begin by reminding ourselves just what aortic stenosis, or AS, is. And at its core, this represents an obstruction of blood flow from the left ventricle into the aorta due to a narrowing at the level of the aortic valve. This valve becomes stenotic when the leaflets of the valve fail to open adequately during systole, and this is typically due to calcification, fibrosis, or congenital malformation. And this narrowing then increases the pressure gradient across the valve. And clinically, we define this by an anterograde velocity of at least 2 meters per second on Doppler echocardiography. Well, importantly, we must differentiate this from aortic sclerosis, which involves thickening and calcification but without a significant transvalvular gradient. But a key point here is that aortic calcification is now no longer thought to reflect simple age-related wear and tear, but is recognized instead as an active and progressive process. So, calcification and fibrosis of normal trileaflet valves is the most common cause of AS in adults and accounts for as many as 80% of cases, with congenitally bicuspid valves typically accounting for the majority of the remainder. Now, in developing countries, rheumatic heart disease still remains a leading cause, but due to improvements in treatment, it's now uncommon in industrialized countries. In rheumatic disease, an autoimmune inflammatory reaction is triggered by prior streptococcus infection that targets the valvular endothelium, and this leads to inflammation and eventually calcification. Chronic kidney disease and disturbances in mineral metabolism are also now increasingly being recognized as contributors to valve calcification due to abnormal calcium homeostasis. Now, AS is the most common valvular disease in the States and Europe requiring treatment, and is the second most frequent cause for cardiac surgery. As you'll know, it's largely a disease of older people, present in about 5% of the population at the age of 65, and around 12% of those aged 75 and older. By the age of 80, almost 10% of adults have it, and it has a mortality rate of about 50% at 2 years unless the outflow obstruction is relieved, so obviously very significant. AS is preceded by aortic sclerosis that affects an estimated quarter of people above the age of 65. Now, the latest figures that we have from 2019 showed that in the UK, almost 300,000 people aged 55 or over were living with symptomatic severe AS, and around 100,000 had asymptomatic severe AS. So I want to talk about what happens to the heart when it faces a narrowed valve. And the key hemodynamic consequence here is increased left ventricular afterload. And so the ventricle must generate significantly higher pressures in order to maintain forward flow. And this pressure overload leads to concentric left ventricular hypertrophy. Now, initially, this compensatory mechanism does maintain cardiac output, but over time, the myocardium becomes fibrotic, diastolic filling becomes impaired, and eventually systolic function may decline. The increased myocardial oxygen demand that this causes due to hypertrophy, coupled with decreased coronary perfusion during a prolonged ejection period, then sets the stage for ischemia, even in the absence of coronary artery disease, a really key point. Left ventricular end diastolic pressure rises, pulmonary venous congestion ensues, and patients then begin to manifest the classical symptoms of heart failure. Now, in my experience, the clinical manifestations of AS follow a well-recognized triad: dyspnea on exertion, angina, and syncope. So that's dyspnea on exertion, angina, and syncope. And these symptoms typically don't appear until the disease is advanced, often after a latent period of some 10 to 20 years, during which the patient may be entirely asymptomatic. Dyspnea reflects increased pulmonary capillary pressures and reduced cardiac output. Angina occurs to increased myocardial demand and reduced supply, and even patients who lack coronary atherosclerotic disease, as I say, may develop symptoms of anginal chest pain, which is a really important point to remember clinically. The syncope is often exertional and results from fixed cardiac output in the face of vasodilation or impaired baroreceptor reflexes. I think it's also worth remembering some non-cardiac manifestations here, because some patients may present with gastrointestinal bleeding, classically associated with angiodysplasia, and an acquired form of von Willebrand disease due to shear stress-mediated degradation of the factor. Others, on the other hand, may suffer cerebral embolic events arising from thrombi on a calcified valve. So let's examine the patient, and on physical examination, AS often presents with a constellation of findings that are as much a test of clinical acumen as they are diagnostic clues in my view. So, the carotid pulse is classically described as slow rising and low in amplitude. This is known as pulsus parvus et tardus. Auscultation reveals a harsh mid-systolic ejection murmur that may become softer as the stroke volume declines, such as in late-stage disease. A single or paradoxically split second heart sound can also be heard, and this reflects delayed closure of the aortic valve. So let's go back to medical school for a minute and just remind ourselves of the grading of murmurs here. And they're generally graded on a scale of 1 to 6. So grade 1, the murmur is faint and heard only with effort. Grade 2, the murmur is faint but is easily detected. Grade 3, the murmur is loud. Grade 4, the murmur is very loud and associated with a palpable thrill. Grade 5, the murmur is so loud that it can be heard with only the edge of the stethoscope. And grade 6, the murmur is extremely loud and heard even when the stethoscope is no longer in contact with the patient. So, as I say, the typical murmur of AS is a systolic murmur at or greater than grade 3, with a diamond-shaped crescendo-decrescendo pattern that peaks in mid-systole and radiates to the carotid arteries. The murmur is generally loudest at the right upper sternal border and terminates with S2 and the end of systole. As the severity of the stenosis worsens, though, the murmur peaks later in systole and may be accompanied by a palpable thrill. Now, when it comes to us evaluating AS, an ECG is indicated in the initial workup of all patients because it's abnormal in over 90% of patients with AS, with the most common abnormality being left ventricular hypertrophy due to pressure overload. Transthoracic echocardiography does remain the gold standard test, and it's essential for the diagnosis of AS, as it can reliably and accurately detect the presence of a pressure gradient across the aortic valve, as well as assessing left ventricle function and for the presence of hypertrophy. Now, NICE recommends we consider echocardiography if the patient has a murmur and no other signs or symptoms, but valve disease is suspected based on the nature of the murmur, family history, age, especially if over 75, or the medical history, such as the history of AF, for example. NICE also say we should arrange echocardiography for any patient with suspected valve disease and signs or symptoms of valve disease, an abnormal ECG, or an ejection systolic murmur with reduced second heart sound but no other signs or symptoms. If you have cases where the echo is inconclusive, especially in heavily calcified valves or low flow, low gradient states, for example, then a cardiac CT or MRI scan can provide additional clarity. In patients with known or suspected valvular heart disease, a chest X-ray is also indicated as part of our initial assessment to assess the presence or absence of pulmonary congestion or other lung pathology. Now, in symptomatic patients with AS, exercise testing is contraindicated, but it is recommended in physically active patients for unmasking symptoms and in the risk stratification of asymptomatic patients with severe AS. If we look at management, this is largely surgical, and NICE recommends we refer to a specialist for adults with moderate or severe AS or bicuspid aortic valve disease of any severity, including mild disease, because unfortunately no medical therapy has yet been shown to halt or reverse the progression of valve narrowing, and this includes statin treatment. Now, while symptom control using diuretics or afterload reducers like ACE inhibitors, for example, can offer temporary relief, unfortunately these measures don't improve survival. Once symptoms appear, the prognosis without valve replacement is pretty grim, with average survival dropping down to 1 to 3 years. So, aortic valve replacement, AVR, either surgically or via a transcatheter approach, is the definitive treatment, and surgical AVR remains the standard in low-risk patients, particularly those patients under the age of 70. However, transcatheter aortic valve implantation, or TAVI, has revolutionized the care for intermediate and high-risk patients, offering comparable or even superior outcomes with reduced recovery times. Now, the decision between surgical and transcatheter approaches is increasingly nuanced, and so should be made by a multidisciplinary heart team taking into account the anatomy, comorbidities, surgical risk score, and patient preferences in each case. If we're looking at surgery, the timing is absolutely crucial. AVR is indicated not only in symptomatic patients with severe aortic stenosis, but also in asymptomatic individuals with a left ventricular ejection fraction below 50%, those undergoing other cardiac surgeries, or when stress testing reveals symptoms or hemodynamic compromise. Echocardiographic progression, such as a peak velocity increase of more than 0.3 meters per second per year, also warrants consideration for early intervention. So looking at TAVI, this can be performed under a general or local anesthetic with sedation, and the process involves a balloon valvuloplasty of the aortic valve, followed by insertion of a specialized valve device, with the whole procedure occurring under fluoroscopy and echocardiography guidance. As a procedure, it's of equal efficacy as surgical AVR in patients who are unsuitable for surgery, and it has 30-day mortality rates ranging from 5 to 15%. But around 1 to 2% of TAVI patients require immediate cardiac surgery for life-threatening complications. Reported 1-year survivals for TAVI range from 60 to 80%, and the majority of survivors experience a significant improvement to their quality of life. But despite successful valve replacement, some patients may not recover full myocardial function, particularly if fibrosis or severe hypertrophy has already occurred. Because remember, as soon as symptoms develop, the prognosis of severe AS is very poor, with survival rates of only 15 to 50% at 5 years, which underscores the importance of timely diagnosis and referral for all of us. So pulling this big topic together, aortic stenosis is a progressive and potentially deadly disease that exemplifies very well how chronic mechanical stress on the heart can lead to complex systemic effects such as heart failure, gut bleeding, and embolic events. Now, advances in imaging and intervention have dramatically improved outcomes, but the early detection and appropriate timing of surgery still remain the cornerstone of care here. As GPs, we must always aim to identify at-risk patients, monitor them closely, and ensure they receive definitive therapy before the irreversible consequences of prolonged pressure overload take effect. So I do hope you found that overview of AS helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help us. But feel free to get in touch via social media at GPnotebook, or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. Visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.